Jason Dragoo came to us from Stanford. He is internationally known for his expertise in biologics. He currently is the Vice Chair of Academic Affairs for the Department of Orthopedics and the head team physician for the Denver Nuggets. And then he directs the Inverness Sports Medicine Center, which includes the CU Stephen Hawkins Clinic. And that's where he practices with many of our providers, and as well as the surgery center and the wonderful PT we have with there. So Jason, man, I'm so glad to have you, and please tell us about the biologics and upper extremity.
Well, great. Thanks, Eric, for the introduction, and good afternoon, everyone. I know we're getting towards the end, and so what better time to chat about biologics and the upper extremity. And as we go through this, let's start maybe at the top, such as the rotator cuff, and work our way down to the elbow. As far as the rotator cuff is concerned, there's been a lot of attention and a lot of literature that really has been studying implant design and suture configuration, and that's getting to the optimization side of the fence. But quite contrast to that is biologic augmentation. There just hasn't been a lot of studies, and it may represent a good future area for improvement of our rotator cuff results. As far as biologics, you can divide them into groups if you would like. One are the growth factors, otherwise known as more of the PRP type of treatments. Tissue scaffolding is another one with regard to rotator cuff tear, and of course the cellular agents previously known as the stem cell therapy types of regimens. So let's go through it with the rotator cuff. And believe it or not, over 21 randomized controlled trials that have really looked at platelet-rich plasma as an adjunct to rotator cuff repair. Long story short, PRP just did not consistently hit the bar with regards to improvements in clinical outcomes or significantly lower the re-tear rate. For those of you who just love PRP and insist on using it in the rotator cuff, there are a couple of little things we can glean from the literature with regards to outcomes. First, PRP was more successful in the rotator cuff tears that were smaller or medium-sized. Also, the use of double row fixation tended to improve the PRP results. And then finally, really activating the PRP clots. That's either with calcium or thrombin, and injecting it right at the bone-tendon interface tended to be the best application of PRP in the rotator cuff. This certainly begs the question, if growth factors aren't enough, are cells necessary to include in our rotator cuff repair? And I think biologically, this sounds plausible because the rotator cuff is often atrophic. I'll give you some evidence of that the local mesenchymal cells are somewhat displaced from the area of the rotator cuff tear. So there's very little cells that are available to direct the repair process. So one of the best steps forward as far as optimizing biology is just insertion site preparation. This has been termed many things in the literature, including bed abrasion, the crimson veil technique, or even local microfracture or microdrilling. Nonetheless, it creates bleeding bone, and with that, some cells, and it's the first step towards thinking biologically. If you want to see the data shows that if you break the studies up into groups that use marrow stimulation or microfracture-like preparation with rotator cuff repair versus rotator cuff alone, the site preparation side does better than rotator cuff alone. So plenty of literature to support your decision. But be careful of patients like this. The arrow is pointing to a patient here with an obvious full thickness rotator cuff tear, but look at the subchondral plate. You see that the line is broken, the subchondral area has edema, which has been shown to displace these mesenchymal cells that are necessary. So therefore, in a patient like this, bed abrasion may not be adequate to get adequate cellularity to the area. Instead, consider doing techniques such as microdrilling, going at least 7 millimeters down into the subchondral bone to really get the source of these cells, which are often displaced in situations like this. Well, here is the article on stem cell augmentation in rotator cuff repair. This has had its own little infamy here because of the results. So this is out of France. Philippe Hernigot, 45 patients in each group. This is matched with rotator cuff repair only and rotator cuff repair with augmentation using bone marrow cells. The great part of this article is that it's a 10-year follow-up, single surgeon doing both arms, and it shows really double the healing rate if you add cells to your rotator cuff repair. The downside to this article, it's the only thing that's out there. And so certainly we need more evidence before we widespread use the technique of adding cells to our rotator cuff repair. Nonetheless, it's a good start. I want to show you his technique because I think we can learn things from it. Here's the technique again out of France, showing him pumping in the bone marrow cells below the area of the rotator cuff tear. But look what happened when he took the needle out. All of the bone marrow aspirate just dispersed from that area underneath the rotator cuff tear. Instead, what can be done is, again, activating the bone marrow. So doing the same thing and adding calcium or thrombin to the mixture can create a gel-like formation of the bone marrow, therefore keeping it intact in between the interface of the rotator cuff and underlying bone. Nikhil Verma and Brian Cole are doing a follow-up study to Hernigau's. So they're about midway through this study, and just to tell you some interim results, they have not found double the healing rate, but they have found with the Sagaya score some more, let's just say, improvements in the rotator cuff repair thickness. So some small level of evidence to suggest that there's improvements, but stay tuned for their final results. In summary, there is some clinical evidence to support the augmentation of rotator cuff repair with cells, but additional randomized controlled trials will be required. And if the cells prove beneficial, they will likely need to be contained at the site of the repair. And I'll show you some techniques to possibly do this. Speaking of that, rotator cuff scaffold has reappeared on the radar. And these can be really used in two different types of conditions. First, augmentation of rotator cuff repair, in a sense, an overlying patch to improve the biomechanics. And I guess you can make some arguments that there can be some improvements in biology. Or interposition grafts, where there is a tension to repair, so therefore you can lengthen the tendon with a graft, and that is more of an interpositional graft. Or you can use this graft in between two bony surfaces, such as a superior capsular reconstruction. In the future, we may have to redefine these interpositional grafts. You see, the lengthening of a tendon is likely to be an interpositional, let's just say, 1 graft, but we suggest that there can be an interpositional 2 graft, which is more of a sandwich in between the bone interface and the repaired tendon. If you use a sandwich graft, it would likely be solely to improve the local biology. So let's look at the literature. As far as the patch over the top of a tough repair, there's pretty good evidence to suggest that human allografts do pretty well in comparison to rotator cuff tears alone. And these are especially in tough rotator cuff repair situations. There's also a lot of literature to suggest that the xenografts don't do very well. And I bring that up today because there's been a resurgence in the xenograft and some recent data to suggest that they do well, which may be true with the new products. But I also wanted to point out that the literature suggests otherwise, and there has been many cases of erythema and drainage with the use of xenografts, so buyer beware, or I should say surgeon beware of xenografts in humans. Interpositional grafts, or detensioning the repairs, has shown also some level 3 success. So almost 60% rotator cuff repair and stability of the repair versus roughly half that with a tensioned repair. And also the according decreased re-tear rate with detensioning the repair. So there is some evidence of interpositional grafts also improving the local situation. But I think in summary, most rotator cuff surgeons feel that these scaffolds are appropriately in only clinically tough scenarios, and their routine use may be questioned. They're costly, inconsistently reimbursed from the insurance companies. There's lack of consistent literature and really unclear biologic benefit. What about the future? Is it possible that these interposition 2 grafts may be useful? Well, maybe, and here's how something could be designed, such as taking bone marrow cells, as Hernico did, soak them in a gel foam or collagen sponge, as you see on the screen, maybe even still doing a local repair site preparation in a bleeding bed of bone, and then place these interpositional grafts with the cells in between the interface of the bone and the scaffold, and then doing your standard repair. What about a few words on biology and muscle tears? Upper extremity, this would be pectoralis tears, especially at the musculotendinous junction, as well as bicep muscle tears. So this is not talking about tendon, which is largely surgical repairs on both. Well, pretty clear evidence to suggest that PRP just doesn't work very well in muscle tears. Matter of fact, more and more results throughout the United States show that injecting PRP into the muscle is not a good idea, with many reports of increasing pain as well as bony deposition within the muscle. We did some basic research on this to really show from a cellular perspective that this appears to be true. PRP did not activate any of the local muscle stem cells that are there naturally at the wound site, but platelet-poor plasma did. And you can see that circled all the way to the left, and you can see the muscle spindle cells that were recreated even in the laboratory with the addition of platelet-poor plasma. In an animal model, you see the bridging muscle that is across an injury, and that is in comparison to the PRP, where you see the disordered scar tissue, which is likely to occur because it upregulates the proliferative side of muscle repair, which is not what we want in this situation. Here's some anecdotal results, and we're using this a lot, including with our NBA and professional players, the use of platelet-poor plasma approximately 2 weeks after their injury, then going through a standard rehab and pretty consistent results. Not necessarily a result of earlier return to play, but the consistent results are much improved look of their MRIs and the muscle planes. So instead of having the interposed scar tissue plane, instead you see that the muscle is just coursing through all the way to the tendon without the scar tissue zone. What about lateral epicondylitis? Well, believe it or not, more than 18 studies have been looked at with the use of PRP versus various other treatments in lateral epicondylitis. And in short summary, the leukocyte-rich type of PRP shows to be one of the best alternatives. If we look at the 3 largest randomized controlled trial, the largest is Alan Mishra's trial here, gives very representative results of the rest of the literature. First, we see that PRP does tend to have better results compared to corticosteroid injection or dry needling. However, if you also look at the literature, there's very little difference in between PRP and the injection of autologous blood. I say that because many of us have Medicaid clinics or patients that just can't afford PRP. So using dry needling and a little bit of autologous blood, at least per the literature, is not such a bad option. This is just a reminder slide of that PRP can be formulated in very different ways, and that there's no such thing as just giving a PRP injection. Taking note that leukocyte-poor PRP is quite anti-inflammatory versus including the white cells is quite often inflammatory. And here's an up-to-date level 1 evidence chart of PRP. And you can see that the white blood cell poor PRP is beneficial in scenarios with inflammation versus the leukocyte-rich or inflammation-producing PRP is much better throughout the list of the tendinopathies. And you see lateral epicondylitis at the top of the list. What about the other common biologic therapies in the upper extremity? Whether it be human adipose or bone marrow cells other than what we talked about in the rotator cuff area, or birth products such as amniotic fluid, no known significant applications as of yet in the upper extremity. So in summary, give biology that same attention that you've been given to your rotator cuff repairs and implants and surgical technique, and think about that local environment and attempt to optimize it when possible, as this may lead to improved healing rates and clinical outcomes in the future. So thank you very much, everyone. Have a great rest of the day, and thanks for having me, Eric.